بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد عليه أفضل الصلاة وأتم التسليم. نبدأ أعمال الملتقى الرابع لأعمال كرسي الشيخ عبدالله بن عبدالمحسن التويجري للأبحاث التطبيقية لحالات الجلطات الدماغية. نبدأ الآن الجلسة الأولى برئاسة الدكتور عبد الرحمن بن محمد السليمان.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. نبدأ الجلسة الأولى وراح يكون تعديل بسيط في المحاضرة الأول. راح نبدأ إن شاء الله مع الدكتور إن شاء الله مازن القحطاني، محاضرة بعنوان طرق العلاج الطبيعي لمرضى الجلطات الدماغية، فليتفضل.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. First of all, I would like to thank the chairman of Sheikh Abdullah bin Abdalmahsen Towijery for giving us the opportunity to talk about our accepted proposal for the grant. And our topic is the efficacy of real-time weight-bearing asymmetry feedback with a graded trunk stabilization and posture control, gait, and functional performance in a patient with a stroke in Saudi Arabia. Many studies has showed that stroke in Saudi Arabia prevalence rate reported as 186 over 100,000 per year. There are many studies have reported that the importance of any kind of exercise for the mobility and functional in adult with a chronic stroke. However, few studies have focused upon the utilization of the real-time weight-bearing asymmetry feedback with the graded trunk stabilization as a part of the main rehabilitation intervention. Stroke survivors have essentially motor defects affecting their posture control, balance, and functional performance and quality of their life. It has impact of standing balance on activity of daily living. It can be significant, and in that standing balance is associated with ambulatory ability to be independent in their gross motor function. We did some literature review. Rائد and his group suggested that trunk control among stroke survivors explained the variance in functional recovery after stroke by 45 up to 71%. The other study by Michael and his group reported that posture control ability while performing functional tasks accounted for up to 30% of the variance of ambulatory activity as measured by their steps account performed per day. Other study by Monaco and his group demonstrated that not only trunk stabilization and standing, but also in a sitting position, postural balance lying, sitting, and standing post-stroke predict functional ability and the distinction at discharge time from the inpatient rehabilitation. Carl and Shepard has stated that the impaired weight-bearing and postural symmetry reflect as a balance and weight transfer defects. Our purpose of study, the main purpose we have is to evaluate the efficacy of real-time weight-bearing asymmetry feedback with a graded trunk stabilization to determine whether it can be improved weight-bearing asymmetry in acute and or subacute stroke patients. We have another purpose, which is to evaluate whether improvement weight-bearing asymmetry during balance task is related to posture control, gait, and functional performance. The methodology of our study we choose to have a subject, 30 subjects, to detect the minimum effect of the power size of our study. Our inclusion criteria: acute unilateral stroke with asymmetry of weight bearing, ability to maintain balance with the minimal assist, and the patient has the ability to understand and follow the instruction. For the exclusion criteria: serious or unstable medical condition, patient has a history other than neurological disease, he has or she has a fixed contracture deformity, and also the patient unable to give informed consent or medically unfit for the training. We will use a randomization list for our participants. We have 3 groups: control group with 10 acute stroke patients, graded trunk stabilization group, and a weight-bearing group. Okay, for the research flow chart, we'll start with the screening, recruitment, and exclude all the other patient that doesn't fit for our inclusion criteria. We'll take the informed consent. We'll do the baseline. Then they will be divided by randomization list to 3 groups: the control, weight-bearing, and the graded trunk stabilization group. All the exercise will be done in these 3 groups. It will be in half hour, 4 days per week for 4 weeks. Then we'll do the post-assessment for each group. The outcome measures: maintenance and change of the postural and balance and coordination ability will be measured by postural assessment scale, what they call PASS, and trunk impairment scale, what they call TIS. Also, we will use the force plate to measure the postural postural imbalance, and will be collected during 30 seconds with a sampling frequency of 50 hertz. In the data analysis, we will use the Smirnov test, box and whisker plots, and a histogram for assessment of normality, independent sample t-test, and a mixed model procedure for assessment type, time pre and post, and group X time interaction. That's all I'm about to say about this study, and this is all our references. Thank you so much.
The other lecture, and we keep it. Our next speaker will be Dr. Khalid Tahami, and his lecture was talking about وبائيات الجلطات الدماغية.
السلام عليكم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الأمين. الشكر والتقدير لإدارة الكرسي لإتاحتهم الفرصة للمشاركة، والترحيب بالإخوان والضيوف الكرام. السلام عليكم. Let us share some information and some slides about strokes, facts and figures, and let us have some ideas and to try to answer some questions about this problem. So it's an epidemiological approach or profile to what we called stroke is the silent killer. Okay. WHO defined the stroke as a rapidly developing clinical signs of focal and sometimes global disturbance of cerebral function lasting more than 24 hours, leading to death with no apparent cause other than of vascular origin. According to this definition, so we can exclude transient ischemic attacks which last less than 24 hours, and patients with signs and symptoms to other causes or other pathologies in the brain like subdural hematoma, hemorrhage or tumors, poisoning or trauma. Stroke always may be ischemic or hemorrhagic. Is it a problem? Yani, is stroke, is it a problem? Okay. Universally, stroke is the second leading cause of death. In some countries or developing countries, it is the third leading cause of death after coronary artery disease and malignancy. And it is the third leading cause of disability among adults. So stroke usually is a burden to the families, burden to the individual, burden to the governments, to the countries, to population, and it cost a lot in socio-economic concern. They said that in average there were, for example, because it is the second leading cause of death, so there is there is one average, or one in the average, one case of cardiovascular disease every 40 seconds, and one case of a stroke every 40 seconds, and one death from the stroke every 40 minutes. Also, according to WHO, about 15 million new cases every year. Cases are more in developing countries. In each 5 cases, 4 of them are in the developing countries. Usually it affects adults more than 20 years of age, and most of the cases are above 55 years. It affects male more than females. The incidence increase with increase of age, reaching up to 100 times. If, for example, you have 3 cases in 10,000 in the third and fourth decades, it reaches up to 300 cases in the 8th and 9th decade. More than 80% of strokes are preventable. If you have a stroke, 10% of these cases will recover completely, 25% with minor impairment, 40% with moderate to severe impairment and require special care, 10% require care in a nursing home or long-term hospitalization, and 15% dies shortly after stroke. In Saudi Arabia, the incidence is 30 to 40 cases every 100,000 of population. And this means that, if we can say that in Saudi population is about 30 million, about 6,000 new cases every year. Why it is less than, for example, in Japan, it is 150 to 250 cases every year, or every 100,000 per year, because Saudi is a young population. As you know that more than 50% of this population is under 15, and more than 80% of this population is under 24. If we made adjustment for this 30 to 40 figures, Saudi Arabia must have, if we make adjustment or standardization, these 30 to 40 cases may be 125. So because it is a young population, not like Japan, we have only 30 to 40 cases every 100,000 of population. The prevalence is 186 cases per 100,000. Statistics shows increased morbidity, disability, and mortality of stroke in Kingdom of Saudi Arabia. And we have a progressive increase in this problem. 70 to 80% of stroke in Kingdom are ischemic. In our city or in our area, we got some information from King Khalid General Hospital, from medical care, medical home care. They have very nice statistics about the number of or incidence of cases per year. And we found that in 34, there were 15 cases reported, 35, 26 cases, 36 last year, 16, and this year, 37, it is 12 cases. And if we see these numbers, and we try to match them with 30 to 40 cases per each 100, we can find that, yes, it is maybe. Because if you consider that Majma'ah city is 50,000 of population, that means we have 24 cases per each 100,000. So still, it is an institute-based information, but it is near the truth. So there are some facts about stroke. It can happen at any age. It is preventable. Most of the cases, 80% of the cases are preventable, especially if we worked on the risk factor. A stroke patient needs immediate management, improvement, continue for life. Some people, they said that, okay, rehabilitation, it is just for sometimes. No, improvement is for life. We can have a stroke with no warning signs sometimes, and more than 75% of lay people can recognize stroke. Out of more than 350 hospitals in the kingdom, and maybe this is a little bit old, the statistics is 2011, but at that time, only in the kingdom we have 2 hospitals that have a stroke team, and only 1 center, only center for stroke in 350, more than 350 hospitals, and only well-trained 2 teams in the kingdom. Only 7 of these hospitals, 7 of them provide thrombolysis. It's estimated that the number of cases treated with thrombolysis is 50 cases per year for the whole population of the kingdom. Establishing a stroke unit, increasing public awareness, training healthcare providers, and collaboration are essential and urgent needs to be met as early as possible in the kingdom. Also, recent studies reported that there is great demand for more rehabilitation center, rehabilitation medicine physicians, and a team of rehabilitation professionals in the kingdom. So we have to prevent stroke other than to treat it. We have to start rehabilitation as soon as possible. We have to think multidimensional to see the different risk factors, and many people, they're supposed to work in prevention, and the work supposed to be in team. Thank you very much.
Thank you, Dr. Khalid, for the interesting lecture. Our next speaker will be Dr. Abdullah Al-Amoudi, and the talk will be talking about توسع الأوردة والشرايين في الجلطات الدماغية.
Bismillah ar-Rahman ar-Rahim. I would like to take the privilege to thank the chair of Sheikh Abdalmahsen التويجري for giving me an opportunity to present today the influence of different diagnostic imaging and interventional technique on a mortality rate in a brain aneurysm patients. I would like to introduce myself as the chairman of the medical imaging department at المجمعة University, and the project being conducted by cooperating between المجمعة University and Rutgers University in New Jersey, United States. The project actually, like, by focusing, I would like firstly to give you like a previous introduction about where can the aneurysm being occur. It could be like in different locations. It could be like in the head and neck, upper extremity, thoracic, and the aorta will commonly occur, particularly like in the abdominal aortic, and last but not least, the lower extremity. So all of these locations where could be the aneurysm occur. So briefly, there are the type of the brain aneurysm can be divided into 2 types: the sacral aneurysm and the fusiform aneurysm, where the ruptured and unruptured could be occur or happened. So an introduction briefly about the brain aneurysm. United States has been divided by the National Institute of Health, the aneurysm as a planning out of the portion of the artery. And all cerebral aneurysm have the potential to rupture and cause bleeding within the brain. About 10 in every 100,000 person per year, about 30,000 individually per year in the United States, and most commonly in people between age 30 and 60 years old. So, this infographic gives you, how, the brain aneurysm or intercerebral aneurysm could be, happen. So 1 in 50 people in the United States every 80 minutes people like in the United States been suffering with the brain aneurysm. There are like 7 risk factors, and these are including like smoking, hypertension, diabetes, and using the drugs. And there are like other like 6 warning signs that could give you like an indication that the patient has the brain aneurysm, and these are included as like a numbness in the hand, like headaches, suffering from the pain in the above the eyes. All of these are like considered as a warning sign for the brain aneurysm. So the topic now, like if we're gonna look at it, there are like 2 types for treatment the patient with the brain aneurysm. Firstly, like by using the clipping, the another one by using the coiling, and these are the interventional treatment. While in my part as an imaging radiologist, you need to select which is the most optimal kind of modality to use to examine that patient. And there are MRI, CT, ultrasound, and the DSA, the digital substructure angiography. So nowadays there is a question raised. The problem background, if we're gonna look at it, there are practical use of medical imaging and repair procedures. We don't know which is optimal, goes for the clipping and coiling before taking that decision. And the first step as a physicians, you need to decide what kind of imaging modality you need to use in that patient, either a CT or MRI, as alternative golden standard for DSA. So after that, you can see from this figure, but with the imaging informatics era and the big data, now we can decide which is optimal. And there are also some confusion. The imaging guidelines, there are hubs of them. There are imaging guideline being published from the American College of Radiology. There is from another foundation, the Brain Aneurysm Foundation in the United States, and from the American Imaging Management. So we don't know as a physicians which one you have to take and to follow in reality. So there is a beautiful statement or quotes being said by Dr. William. That was in 2015. I was in that beautiful conference. He said everything is different than it was a year ago. Why? Because the big data we have. So the problem statement for this project was many studies being indicated, either risk interventional repair procedures by measuring, by looking at the coiling and clipping and look at the mortality rate, and that's it. And other studies being just looking at the accuracy in terms of the sensitivity and specificity of using different imaging modalities. So the study gap here, if you're gonna look at it and combine them, the study were conducted only and done on the negative consequences of interventional aneurysm repair, while the combining the technique have not been conducted with the lack of sufficient studies to evaluate the evidence-based practice in imaging guideline and healthcare benefits. So we are trying to reach the best performance and best care performance in healthcare. So the study will fill the long-filled gap of relating imaging modalities and repair procedure management in hospital mortality with the brain aneurysm patients. So the material and methodology being used, firstly, the categorizing of our data elements. In fact, the data being conducted from the National Institute of Health in the United States, the number of records were about 13 million records. And to reach to the optimal where it can really meet our criteria, the patient has to have one of these 2 types of the brain aneurysm and being examined with the CT or MRI, and being also surgical being procedure and performed under one of these, the coiling and clipping. Also, the patient has to have, in his record, one of the demographical factors, plus the insurance type, the comorbidities. Also, the data were, including the hospital volume, either, the size of that hospital, and the admission type. Did the patient being admitted at the ER or being admitted, at different, admission? Hospital status and the location of that hospitals. And the hospital region, either is it up north, east, is it in the south, in the Middle East, so or west part of the United States, and then measuring the in-hospital mortality, did the patient die or didn't die. The result, it can be shown, it's normal distributed, which is it give us we can perform and proceed. And the result, as can be shown, it commonly, occur in the age between 45 to 49 up to 94 years old. And then we can see some decreasing, like, in the number. And the result for our patient gender were about 441, about 70% of them, they were male, and 30% were female. The data, as we can see, the distribution on the map of the United States, it's commonly occur in the Midwest, the Midwest, yes, and in the middle part of the United States, where the up north, it's not that common. Texas, Florida, Texas and Los Angeles, where the California states were not that much covering, or I would say suffering from that. So the result of the diagnostic imaging procedures, CT, were 523 patients being underwent the CT procedure, while the MRI were about 112. The interventional treatment, the clipping were about 20-30% of these patients being underwent the clipping, 63% were coiling. And some patients, we find out that about 14% were performed under both of them, clipping as a stage 1, coiling as a stage 2. So what we find out, the comorbidities, one of the most reason for having the brain aneurysm in the United States was the hypertension. And the majority, they were white people, about 87%, which is a bit shocked. Patient health insurance, the majority, they were Medicare patients. And the future research and recommendation, applying a predicting model for the future research. Now we just build a probability model, while now there is another modeling, which is a prediction modeling. We can do that by using the time series. And the future research need to consider a survey of a Saudi hospital to evaluate their guidelines. Unfortunately, we take this as a stage 2 because the kind of obstacles that we are facing, here to conduct this kind of research. So I would like to thank the faculty chair and the committee member for joining and for the beautiful listening. Thank you so much, really, for your time. I appreciate it.
Thank you, Dr. Abdullah, for the interesting lecture. And I think there is a lot of information, there is a lot of data that needs to be discussed, and really interesting about it, really. So we may have a chat later on to discuss about it. Our next speaker will be Dr. Sadiq Yusuf. And he's going to give us a lecture about prevention and management of stroke.
بسم الله الحمد لله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله. في البداية نشكر أسرة الشيخ التويجري ونشكر القائمين على أمر هذا المؤتمر. My presentation will be stroke prevention and control. Stroke is defined as acute neurological changes lasting more than 24 hours by interruption in blood flow to a part of the brain. If blood flow ceases of an extended period of time, the cerebral tissue involved dies, causing permanent neurological deficits. This is some statistics. Stroke actually is a leading cause of serious long-term disabilities. Each year, approximately 800,000 people die, not suffer, die from strokes. 90% of strokes are attributable to modifiable risk factors, and 80% of recurrent strokes can be prevented by optimal management of risk factors. There are two main types actually of stroke. One of them is ischemic stroke, which is prevalence is around 84 to 86%. Ischemic strokes are due to a blockage of the artery, resulting in a reduction of blood flow and cell death. The second one is the hemorrhagic one, which is constitutes about 13%, occurs due to bleeding into the parenchyma of the brain and making the same sequelae. Why do we need to prevent stroke? Actually, 80 to 90% of strokes are preventable, and stroke survivors are at high risk of another stroke, 5 times chance recurring in 3 months. Mortality and disability after recurrent stroke is higher than after the first stroke, so we have to intervene by some sort of control. It is projected that the cost for treating strokes will be rising throughout the next decades. And now we come to the risk factors of stroke. There are two types actually, well-documented risk factors and less well-documented risk factors. Well-documented are hypertension, cigarette smoking, atrial fibrillation, dyslipidemia, asymptomatic carotid artery disease, and so on. And the less documented are the metabolic syndrome, excessive alcohol consumption, drug abuse, use of oral contraceptives, sleep disordered breathing, migraine, and so on. These can be also classified to modifiable or non-modifiable risk factors. The modifiable, such as hypertension, diabetes, smoking, dyslipidemia, alcohol, diet, physical inactivity. And the non-modifiable, as advanced age, race, and sex, family history, and genetic disorders such as sickle cell anemia. Also, modifiable risk factors can be classified into medical and behavioral. Medical such as hypertension, diabetes, dyslipidemia, and the behavioral such as smoking, alcohol, physical inactivity, diet, medication compliance. Now we come to deal with some management of some risk factors. Hypertension, the major cause of stroke, defined as systolic blood pressure more than 140 millimeter of mercury, or diastolic more than 90 millimeter of mercury. Blood pressure lowering associated with 30 to 40% reduction in stroke incidence. We recommend in case of hypertension to optimal drug regime to achieve the recommended level of reduction, and lifestyle modification, which is very important, such as salt restriction, weight loss, diet rich in fruits and vegetables, low-fat dairy products, regular physical activity, and stop alcohol consumption. These are modifiable risk factors and can be, all of them dealt with to reduce the prevalence of hypertension and hence reduce the prevalence of stroke. Number two is diabetes, prevalence around 15 to 33% in patients with ischemia. 99% of recurrent strokes has been estimated as being attributed to diabetes. We recommend use existing guidelines for tighter glycemic control and blood pressure targets in patients with diabetes. Also, diet, exercise, oral hypoglycemic drugs, and insulin are recommended to gain glycemic control. Regarding cigarette smoking, is a major risk factor for ischemic strokes. We recommend quit smoking and also avoid passive and second-hand smoking, which is very common. To have these people, sometimes they don't give much attention to this type of smoking, and also counseling, managing nicotine products, medications are effective for helping smokers to quit, and also raising awareness. Number four, lipids, elevated total cholesterol or low density lipoproteins cholesterol is associated also with increased risk of ischemic stroke. In this case, we recommend lifestyle modifications, dietary guidelines, and medications. Physical activity as a risk factor. Physical activity exerts a beneficial effect on the multiple stroke risk factors. Moderately or high active persons had a lower risk of stroke incidence or mortality than did persons with low level of activity. Then physical activity lowers blood pressure and weight, enhances vasodilation, and improve glucose tolerance, and also promotes cardiovascular health. Metabolic syndrome in patients with ischemic stroke, the prevalence is around 40 to 50%. Recommendations are appropriate treatment for individual components of the syndrome that are also risk factors of stroke, particularly dyslipidemia and hypertension, and also treat the underlying causes. Alcohol consumption, chronic alcoholism, and heavy drinking are also risk factors for all stroke subtypes, and we recommend as Muslims to quit having the alcohol consumption. Now we are going to move a little bit to stroke in risk in women. It is the third leading cause of death in women, and these factors that are unique to women are reproductive factors such as pregnancy and preeclampsia, oral contraceptives, hormone replacement therapy, and other factors than the reproductive are migraine with aura, smoking, obesity, metabolic syndrome, and cerebral vein thrombosis. We recommend in case of women to screen women for high blood pressure before prescribing oral contraceptives and prescribing medications for pregnant women with moderate and high blood pressures, and also investigate whether patients had preeclampsia during pregnancy, and this can be done through the antenatal care. And thank you.
Thank you, Dr. Sadiq, for the interesting lecture. We may have 3 minutes for discussion if you'd like, if there is any. If there is nothing, we may have a break for 10 minutes, then we'll come back again for the next session. Yes.
I would like to ask Dr. Muhammad Amoudi, there is any preliminary study in Saudi Arabia about these kind of things? Is any preliminary study in Saudi Arabia? Any data?
Okay, good. Yeah, what I was saying, like, unfortunately, like, there is no kind of study being performed with this kind of like a study, especially like, in the era of the big data. As you know, like, we are suffering with the electrical health record now in Saudi Arabia. It's just like, when the stage of the implementation where like, all these kind of records could be really, inshallah, like within maybe 5 years from now being registered, and we can do and perform this kind of study. But like, there are like, some specialist hospital like the King Abdulaziz University. They do have like electrical health record for like about, I think maybe 13, 14 million record. So we most likely, inshallah, with Dr. Mohammed al-Mukhlafi, who's the neurologist, neurosurgeon in reality, who's so interested and enthusiasm to perform this kind of research. So hopefully, like, inshallah, we can do like, this. But unfortunately, like, with the guidelines, where like it's the best line to do this kind of study, as you know, doctor, like, different hospital has different guideline, and there is no standardizations, especially in Saudi, and even in the United States. United States having the same issue. As you saw, like, there are like, the American College of Radiology having their own guideline, and there are like many recommendations to complain their guideline, and but there is no evidence-based practice to reach to that like best practice to evaluate that guideline before implemented. It's just like a physician prevalence. Some physicians, they are feeling like more comfortable to diagnose the CT images, while other, they really would recommend to use an MRI. But in the reality, based on what? It's just like, a physician preference. But I believe with these kind of modeling, now we try to implement, such as like, the predictions and the probability modeling, I believe like these can be used as a clinical decision support system, where the physician can do something based on evidence-based, not like on their like, preference. So hopefully, inshallah, this could be all, inshallah, considered in the near future. Thank you. Do you have like another question, please?
Hello. So I found all of the talks so far very interesting, and I'd like to ask any of the speakers to respond to this question. So if I compare things that happen around Greater Manchester in the UK, so now we're moving towards translational and we're moving towards stratified medicine. So we're moving towards a time where we're stratifying and identifying an individual person's risk of developing cardiovascular disease and of developing stroke. And then we're looking to sort of modify and make lifestyle changes to reduce their risk from an early age as possible. So what I'd like to know is the city of Al-Majma, where do you think you're going? Are you going in this sort of direction? Are you looking to identify people, at an early time who are at risk of developing, and then modifying those modifiable risk factors? So that's my question to anybody.
To be honest with you, Dr. Mark, it's unfortunate, like, it's like an open talk, of course, and we have to be realistic and saying the truth about what's going on. I believe, like, the public health as a concept is just being implemented recently in Saudi and being activated. So I believe, inshallah, like, with Dr. Tawfiq al-Rabi'a, who is now being in charge for taking this and to play, like, a role in healthcare in Saudi, I believe, hopefully, like, this will be, like, taken in consideration. While, like, now, they just being tried to not identifying these kind of factors, while instead of focusing, implementing the basic of the public health in Saudi. So hopefully, this answering, like, you concern.
Any question?
My question is for the first speaker, and I wonder what is the design of this study? Is it a a randomized control trial, or is it a quasi study?
I think this question for Dr. Mazen, right?
Yeah.
Okay. Dr. Mazen?
Yes, doctor. It's a randomized control trial, and actually we hope our 30 subject is fit for because we choose 30 subjects as minimum to detect the minimal effect size of our study power size. Do you have any question, doctor?
Any question? Okay, thank you for the audience and also thank you for the speaker. We're going to have a break for 10 minutes and we'll come back again inshallah for the next session. Thank you very much.
نشكر لكم حضوركم واستماعكم لبرامج الجلسة الأولى لأعمال الملتقى الرابع لأعمال كرسي الشيخ عبدالله بن عبدالمحسن التويجري برئاسة الدكتور عبد الرحمن بن محمد السليمان. نبدأ الآن الجلسة الثانية برئاسة الدكتور خالد بن محمد العبد الوهاب.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Welcome back again for the second session today, and we'll have three speakers. We'll start first with Dr. Khalid Al-Ghamdi, who's the head of the physiotherapy department in King Khalid University Hospital, and he is going to talk about rehabilitation of stroke patients. Please, Dr.
السلام عليكم ورحمة الله وبركاته. السادة الحضور، السلام عليكم ورحمة الله وبركاته. الحمد لله الذي وفقنا للعمل على إصدار كتاب العلاج الطبيعي والتأهيل الذي هو ثمرة لمجموعة من استطلاعات الرأي من خلال الأبحاث التي قدمها كرسي الشيخ التويجري رحمه الله، ومن خلال التواصل مع الممارسين الصحيين، ومن خلال البحث في المكتبة العربية عن مثل هذا الكتاب الذي يجيب ويلبي ويوجه المريض بالسكتة الدماغية عافانا الله وإياكم، وأثناء الاحتكاك بالمرضى وعائلاتهم من خلال الخدمات العلاجية التي قدمها الكرسي منذ إنشائه. لذلك كان هذا الإصدار منقحا وشارحا للمتخصصين آخر ما تم نشره من أبحاث عالمية بلغة قريبة من فهم المجتمع والغير متخصص، ليسهل على المصابين أو ذويهم الفهم والتعامل الأمثل مع السكتة الدماغية. يعرف هذا الكتاب السكتة الدماغية والتغيرات الفسيولوجية سواء في مرحلة الاكتشاف المبكر وأنواع السكتات، كما يشرح تركيب المخ وما هي الأضرار التي يمكن أن تنجم إثر تعرض الدماغ لها، والتعامل الطبي معها وكيفية تقليل أعراضها وطرق العلاج والتأهيل، شارحا كل مرحلة من المراحل التي يمر بها المريض وتوجيه المرافقين للمريض باتباع تعليمات الفريق الطبي، وشرح الدور الذي يقوم به والذي من أثره تقليل المضاعفات لكي يستطيع المريض الخروج منها بأقل ضرر يذكر. كما يسلط هذا الضوء الكتاب على الدور الفاعل للتأهيل والعلاج الطبيعي من استعادة الحركة وشرح الأساليب المتقدمة وجمعها سويا في هذا الكتاب. كما تتطرق صفحات هذا الكتاب لشرح أسباب الجلطات الدماغية ثم الوقاية من الإصابة بها. كما يشرف هذا الإصدار إضافته للعديد من عناوين مستشفيات طبية متخصصة ومراكز علاجية في المملكة العربية السعودية وفي مختلف أرجاء العالم، وتقدم خدمة العلاج والتأهيل كبادرة غير مسبوقة لهذا الإصدار. نهاية أشكر كل من ساهم في تأليف هذا الكتاب، وهم الدكتور رائد البرادعي، الدكتور محمد قطب، والدكتور سلامة الدعجة، والدكتور مازن القحطاني، والدكتور محمد الثبيتي، والدكتور خالد الغامدي، والذي قام بمراجعة هذا الكتاب الأستاذ الدكتور سامي العبد الوهاب والدكتور محمد القاري، وتم الإعداد الأستاذ عادل عبد الكريم. كما أتقدم بالشكر الجزيل لمعالي مدير جامعة المجمعة على ما يقدمه من دعم متواصل لكرسي أبحاث الشيخ عبدالله بن عبدالمحسن التويجري رحمه الله، والشكر موصول لأبناء الشيخ التويجري حفظهم الله على كل ما يبذلونه من دعم ورعاية لكرسي البحث، جعله الله أجره موصولا لهم ولأبيهم. والسلام عليكم ورحمة الله.
دكتور، عندي سؤال لو سمحت. يعني هذا الكتاب ممكن نعرف بس جزئياته، عن ماذا يتكلم يعني، أو عناوينها الجانبية إذا كان في إمكانية؟
الكتاب يتكلم عن أسباب إصابات السكتة، تعريف السكتة الدماغية وإصابات السكتة الدماغية والتغيرات في الوظائف الفسيولوجية للدماغ وتركيب الدماغ والدورة الدموية للمخ والتعرف على حالات السكتة الدماغية. هذا في الباب الأول. أما الباب الثاني فهو يتكلم عن علاج السكتة الدماغية وآثارها وأنواع المداخلات العلاجية للسكتة الدماغية. الباب الثالث يتكلم عن العلاج الطبيعي والتأهيل لمرضى السكتة الدماغية من عناصر التأهيل ومراحل العلاج الطبيعي ودوره في التأهيل لكل مرحلة ووسائل العلاج الطبيعي التي تقدم للمريض والعلاج الطبيعي للمرحلة الأولى والمرحلة الثانية والمرحلة الثالثة وخدمات التأهيل الأخرى التي يمكن أن تقدم للمريض. أما الباب الرابع فيتكلم عن التوعية والوقاية من السكتات الدماغية ويتكلم عن مراكز العلاج الطبيعي التي لم تذكر إلا في هذا الكتاب. جمعت جميع مراكز العلاج الطبيعي التي تقدم خدمة العلاج الطبيعي للمريض ليسهل على المريض الوصول إليها والتعامل بها في المملكة والعالم.
يعني الكتاب يحتوي على جميع مراكز التأهيل داخل المملكة وخارج المملكة.
داخل المملكة وخارج المملكة.
وهذه تعتبر أول كتاب يعني.
أول كتاب يجمع بين هذه المراكز المتخصصة في التأهيل والعلاج الطبيعي.
في الجلطات أو بشكل عام؟
في الجلطات.
ما شاء الله جميل. I think we will have some change in the schedule. And the next talk is going to be by Prof. Mark Slevin. He's well known to us. He's going to talk about using stem cells in therapy of stroke. So please, Prof.
Good morning, everybody. And many thanks for the invitation once again to come here and talk to you. Now, I think I remember a couple of years ago, I introduced the subject and talked a little bit about the potential for stem cells and stem cell therapy as part of a talk that I gave. And it's interesting that we've had some presentations earlier on, and we're talking purely about how can we improve recovery after stroke. Can we look at the modifiable risk factors? And what we're not really talking about, and again, I'm not going to talk about either, is could we prevent stroke? You know, so could we prevent that 80 to 90% of ischemic stroke from occurring? And apart from modifiable risk factors, which will make a difference, you have genetics, you have epigenetic changes, lifestyle issues, and these start from before birth, you know, so there are changes in the stress of the mother during pregnancy which may eventually lead to you developing a lack of ability to control stress in your life, which will then predispose you to hypertension, for example. So there are lots of it's quite a complex multifactorial situation. But to summarize, I would say that in the future, what we're looking at is we're looking to not see stroke occur. We're looking to prevent cardiovascular disease and cerebrovascular disease. And if, for example, we had a mechanism for self-repair of the blood vessels, so the carotid arteries, the coronary arteries, for example, and maybe even some of the smaller vessels like the MCA, by nanotechnology and nanorobots, I'm sure that in the future we'll have to change the style of our presentations, and we'll be really looking at saying, well, actually it's quite rare that a stroke occurs because we're able to protect our blood vessels. Our carotid arteries are not building up plaques. We're not developing thrombosis because we understand the mechanisms, and we have our new preventative stratified medicines which will mean that we can live to an old age without actually having a stroke. So I think that I hope in 10 years or 20 years from now I'm here and we're talking a slightly different way about stroke and about how to make sure that we're people are living healthy lives into their 90s and 100s. So it's a slow process. 5 years ago, I was giving a talk saying, there's been no new treatments, effective therapies for stroke in the last 2 decades. And we're still saying that now. So there isn't really anything else out there. However, over the last 2, 3, 4, 5 years, quietly, there's been some clinical trials, okay? So we know that animal models are not a very good representation of looking at human stroke and human atherosclerosis and the pathophysiology of what happens after stroke. They're quite different. There are some similarities, but the timing, the processes, excitotoxicity, inflammation, apoptosis, vascular regeneration, they're a bit different. So really, one of the reasons why experimental stroke therapies in the past have worked in a mouse or a rodent model and then haven't worked in a human is explained by the fact that they're quite different, the processes. Now, I just picked up a handful of papers here on my way in, and we have one article, good article from this year, which is saying effective double administration of mesenchymal stem cells following cerebral ischemia in rats, okay? So we're still looking at stem cells. We're injecting them arterially, intravenously, into rodents and seeing if there's any improvement in stroke. Do they recover? Do they get an improved cognition? Do they have better motor function? These are stroke volumes reduced? Do they live longer? Etc., etc., okay? And then I picked up a very, very recent, this year, review, which surprised me slightly because it lists the total number of clinical trials that are ongoing using stem cells in humans. And I was aware of 2, and there's about 8 here around the world. Okay, so these clinical trials are either phase 1 or phase 2, so they're not gone beyond phase 2. They're looking at people who are very seriously affected by stroke, so severe ischemic strokes. Sometimes they've injected stem cells intra-arterially, intravenously, and occasionally they've made a borehole and directly injected stem cells into the cranium, intracranial, into the brain. And this excited me when I looked at this, and I realized that, yes, we do it, it's been done in animal models, but the thought that you theoretically, stereotactically, and very carefully could inject or target in a certain way the stem cell therapy, such that you've got a higher concentration of the cells which will remain in that hypoxic environment, which is where you need them, and then looking at the activity of those stem cells, how they may help to generate remodeling new neurons as they differentiate, and possibly into glia, and also affecting the vascular system from release of cytokines, which are pro-angiogenic. So many, many factors which might help to reduce the damage and improve the recovery after stroke. So that's my little introductory summary, and I can go through the slides now with you having that little bit of background. I think it helps. And just, again, to be aware of reality, which is when I gave a similar talk in Nottingham University a few months ago, and I said, yeah, here we go. So what's the first thing to do? As soon as possible, as soon as you know a person has had a stroke, what do you do? Can you use TPA? Can you remove the blockage? Can you give them then some new therapy, our novel therapies of the future, And the question came back straight away, well, how long is it normally before you have a patient, they're in the hospital, and you're able to give them a treatment? Okay? hours or longer. Normally it could be 8 hours, 12 hours, 16 hours, 24 hours. In the NHS in UK, you might go into accident and emergency with a very severe headache, and it may be that you have symptoms that you've had a stroke. It may still take 6 to 8 hours before you're diagnosed and you've had a scan, and then they start thinking about giving you therapy, okay? So in those first 8 to 10 hours, a lot of things happen in the brain after stroke. And is it too late, you know, to sort of, for certain part of the brain, is there already necrosis, you know, the stroke core? So we need to think realistically of the future and say, in 10 or 20 years' time, the first stage of any new treatment will be done in an ambulance, okay? So as soon as you're picked up, you don't wait till you go into the hospital. You don't wait to get a scan in the hospital. You don't get triaged. You actually get your therapy starting there and then in an ambulance, which is prepared, okay? And that can be done within a couple of hours, theoretically. So more people are picked up at the point where they can be treated more effectively. So, combinational, targeted stem cell therapy. Combinational because it's a complex disease. There is no way that one drug is going to do the job, okay? Effectively. It's not going to do all of the things that you would like to do to help to repair the brain as effectively as possible. Targeted because if you don't target something, it will become dispersed around the body. So if you inject stem cells even into the brain directly, many of them will then be lost into the circulation. And if you inject them intravenously or arterially, the majority of them will not reach the brain, even though they have a little homing or sensing mechanism which tends to promote their movement towards hypoxia or low pH, which is what you find after stroke. So I think I've done well to spend almost 8 minutes on the first slide, so I better move a little bit quicker now, because Ra'id said, expand your thought. Have we got time? Okay, so good. Now here's some of the collaborators. In a project like this, you can't do all the work yourself, okay? We're always competing against United States of America, okay? Because and often China, because they work very quickly and effectively. And if they hear about something, they're onto it straight away. So we need to be able to compete, and we therefore spread the work around, and we do combine it together. So we have University of Targum. Is it not showing on the screen? Why? So that's not a good start, is it? Perfect. So we have University of Targu. This is in Romania. We have University of Brescia in Italy. We have Majma, which is here, and one of the small project grants has helped us to derive some of the data that we're using, which I'll show you briefly as well, and University of Manchester, working very closely together with ourselves. We also have Fraunhofer Institute of Cell Therapy in Germany. It's funded by several external charities. Right. Physiology of ischemic stroke. I don't need to stay on this slide for more than 10 seconds because we've had some nice presentations this morning. Everybody knows what happens when you have an ischemic stroke. In the majority of cases, thrombus release from the carotid artery, and it usually blocks the middle cerebral artery. And that's the way, when we look at models, and until we get proof of concept for a new therapy, we're looking at usually rodent models to start off with, and then occasionally we're using larger mammalian models. So this is the type of model that we're going to use. This is what happens after stroke. If we're using a model, we're going to block the middle cerebral artery inside the animal by cauterization or by filament, okay? So current therapies is TPA. And this is approximate timing, and this is in the UK, of how you might get your treatment. And if there's a little mouse there. So, suspected at time 0. Now, ambulance, I don't know how long it would take an ambulance to get to your cells here, but little story. I was in Barcelona a couple of years ago, up a mountain on a mountain bike in the middle of nowhere, so on a track, okay, which was impossible really to get to by ambulance. 20, 30 kilometers from the nearest hospital. And I was going down a hill with one of my close colleagues, Professor Jurek Krupinski, and we were going down very, very fast on mountain bikes, and I hit a rock. Okay, so I hit a rock. That's the last thing I remember. I went over, hit my shoulder and my head on other rocks, was unconscious for a couple of minutes, came round, bone sticking out of my shoulder, couldn't move. 5 minutes later, there was an ambulance at the nearest point, which was about 200 meters away from where I was. 5 minutes, okay? That's quick. That's the sort of service you want. Now in Manchester, okay, I was in hospital then. I got back to Manchester having the plates put in my shoulder, and there's a guy next to me who had basically an accident on his bike, broke his leg, bone was sticking out, it was awful injury. And it was just, Ra'id will know this very well, anyone who's been in Manchester, it was just by Umist, okay, which is very close to the Manchester Royal Infirmary. And I said, oh, that's a really bad accident you've had, you know, it looks nasty, that injury. He said, yeah, it was awful. He said, you know, call the ambulance. It took an hour for them to get here. An hour to go half a mile, okay? So, you know, this is really critical. This is the most important thing. So these timings are ideal timings, aren't they? You know, you want as many people as possible to be getting into an ambulance as soon as possible, and then we want the ambulance to be able to start treatment in the future. So from point of contact to sort of trying to remove the blockage should be an hour, ideally. Now, I mentioned to you the complexity of pathophysiology of the stroke, and I think everybody in here knows about it. Now, apart from the complications of transient ischemic attacks, where you're not necessarily sure you've had a stroke, or you have very small sort of embolic or sort of lacunar type strokes, and sometimes you're not aware of it. These bits of damage then go on eventually and predispose you to dementia. Apart from these things, when you have a stroke, these are the approximate timings. So excitotoxicity, so you get masses of glutamate released, and then the calcium gets inside the neurons and damages the cells, induces apoptosis. Okay, so you have very, very quickly, in response to hypoxia and lack of oxygen, this process. Now this process then stimulates, as I said, apoptosis and inflammation. So inflammation is starting within the first couple of hours. It's very, very damaging, okay? Normally inflammation can be a good thing, but in stroke it's a very bad thing. So the size of the stroke volume is mainly determined by how much inflammation there is. So our colleagues in University of Manchester, led by their Vice-Chancellor, Nancy Rothwell, spent 20 years or more trying to find something which will block inflammation after stroke. And they got it to clinical trials. So it was called an interleukin-1 beta receptor inhibitor. So it blocks all the signals that go through that receptor, and 90% of inflammation can be stunted. It failed beyond stage 1, and they found that it was too big to get through the blood-brain barrier, even after a stroke. They couldn't deliver it properly, couldn't find a mechanism to get it there, sufficient quantity, and actually make it effective in the human study, even though it worked in a mouse and a rat model stroke. So inflammation is absolutely critical, okay? We may not be able to do much about excitotoxicity because it occurs almost immediately after stroke. But the downstream effects of excitotoxicity, apoptosis and inflammation, maybe we can start to think about protecting them. If we can treat somebody within 6 to 12 hours or even 12 to 24 hours, the peak of inflammation is 24 hours and 2 days and 3 days, okay? It's quite different in an animal. In an animal, it's 12 to 24 hours, but it keeps going in humans. If we can slow that down and stop it in the first 12 hours, we might be in business. And later, you have angiogenesis, tissue remodeling. It's worth remembering that angiogenesis at the beginning is not a good thing, okay? So if you add, in the past they tried VEGF as a growth factor for trials and found that it made the stroke worse because it increases permeability, and it actually increased the amount of inflammation in the stroke, and the consequences were worse. So once inflammation has subsided, tissue remodeling is good. And we know now from fairly recent papers that there can be improvement over months and over years due to further remodeling of the neuronal artery system. So that's how it looks to me. Well, so at the moment, I'm going to make a few bold statements, very simple, very obvious. TPA, there's going to be a problem if we can't recanalize the artery, okay? So if you can't do that, you can't effectively get drugs to the damaged area unless you go intracranially or intranasally, okay? So intranasal is another potential way of being able to deliver drugs into the brain, and it's something that's being focused on in detail now. Mentioned just underneath there, there's a potential to overcome the endothelial barrier using microbubbles. This is a fairly new technology using ultrasound, which then damages the bubbles, opens basically the blood-brain barrier, but without damaging the cells. This has been tested in models, and it seems to work, but it's not been tested really in human trials. So we go to stem cells. And we spent the last few years working with people, particularly in Italy, looking at omentum-derived, fat-derived, mesenchymal stem cells. There are other types of stem cells, but these types of stem cells are quite easy to obtain from an individual patient, and they appear to have the following properties. So they can home to ischemic regions automatically. They like to go towards ischemic regions. You can modify them, their phenotype. So this can be pro-angiogenic or anti-angiogenic. So remember what I said before, you may want them to be anti-angiogenic in the first couple of days after stroke, but you may want them to be pro-angiogenic 3 or 4 days onwards after stroke for remodeling purposes. And I think the most interesting thing is they can carry drugs and release them over time. And that's up to about 3 days. So if you think about something which is continuously releasing a drug, this is much more effective than an injection, for example. But it's going to last a lot longer. Hyperacute phase, excitotoxicity, will we ever be looking to try and do something about that? If so, stem cells won't be much good because they are slow release. You're looking at something like liposomes, nanotechnology, something with rapid delivery and targeted delivery into the brain if you catch somebody very, very early after stroke. What type of drugs? I'm coming on to that in a minute, but there are drugs which block NMDA receptor function and therefore will reduce the effects of glutamate damage. But what about what I said in the beginning about the trials? So the one particular one that I'm aware of that some of my colleagues are working on is from a company called Reneuron, and this is called the Pisces study. So it's on stage 2 now, phase 2 trial. Phase 1 demonstrated that when they injected these stem cells into the brain, there was no toxicity, no negative effects. Okay, so that was given a tick, and they're allowed to move on to phase 2. Phase 2 trial, okay, is involving, because they're in process of doing it now, injecting cells into the brain of people who've had a severe stroke, ischemic stroke, 2 to 12 months after, and then looking at the long-term effects to see if they benefit. So they're going to do it on a small number of seriously ill patients and use these criteria to judge if there's any beneficial effects. Now, there's a lot of studies now in animals, and not every single one of them have demonstrated a positive effect of stem cells on stroke recovery. And this might be partly because in many of those experiments, the stem cells don't get to the damaged area in effective numbers. Because I think if they do, they should have some beneficial properties. And particularly in an animal model, the brain is much smaller, the skull is much thinner, it's much easier to get stem cells there than it is in a human and to target them. So going back to this diagram, which we've seen already, looking at the hyperacute excitotoxicity, our collaborators, first of all, have shown that cancer drugs can be loaded into the stem cells. So I don't want to talk about cancer, but this is how it started off. It's only 2 or 3 years ago. And they passed this information to us, and I immediately thought, well, I wonder if we could put some drugs that may be useful in stroke into the same cells. And then I thought, which drugs? Because there aren't that many useful choices at the present moment. Hyperacute phase, no good for stem cells. Memantine, for example, could use that with a liposome type therapy, block the effects of glutamate and calm down this excitotoxicity. So this is just showing you a little bit of the detail about how that would work. Would reduce the amount of calcium that's inside the cell. The calcium then goes on to activate calpains. Calpains then activates a series of cell signaling pathways, including cyclin-dependent kinase 5, P35, and that induces apoptosis through P53 and caspase. I guess nobody wants to know details of signaling pathways, and it's not interesting to me either, but unfortunately I have to be aware of those just when we're looking at targeting specific molecules. So that's how that would work. And that's how I think that if there is a hyperacute therapy, you would make a liposome, you would attach these type of drugs to it, and people are trying to do that, such as Zhang et al. Last couple of years. So this could be part of a future therapy. So I've already mentioned some of the properties of these stem cells, and we're looking at the inflammatory phase of stroke. So we might use the stem cells with a phenotype that's anti-angiogenic. We said they're home to ischemic regions. This is a picture of what it looks like, the stem cell, when it's loaded with the drug. And as I said before, they can release the drugs over up to 3 days. Now, what drugs? Okay, what drugs could we use? We've worked with the small project grant that we had here, and we've also been working previously to that for 3 years, just to characterize a drug now it's called P5. It can also be called CYP, which is CDK5 inhibitory peptide. And it's a small peptide which blocks all of the signaling, all of the abnormal signaling, which is produced when calpains break down this protein P35, producing a P25 fragment which binds to CDK5, which is listed there. Here, CDK5. When it binds to CDK5, it causes death of the cells. And actually 90% of the neuronal death is thought to be caused through that pathway. So we chose this new drug. Well, this is a new drug that was first of all introduced by our collaborators in the United States. Then we've modified it, they've modified it, and we've made it very small. And it's equally or more effective now than it was at the start. So what are the advantages of this now? We've characterized it inside stem cells, and I'll show you a couple of pictures of this. It goes into the stem cell, and it's released out of the stem cell in a quantity which is sufficient to block this pathway. This means that if we put this drug in the stem cell, got it into the brain, into the ischemic region as quickly as possible, it would be released over up to 3 days, potentially blocking apoptotic cell death. So it might actually keep a substantial proportion of neurons alive during that critical period when they're, sort of undergoing damage. Very, very briefly, we had to do lots of characterization studies. This is immunofluorescent or triple immunofluorescent study. We needed to know what the function of that CDK5 protein is. So we wanted to know, if we block it, are we going to damage any normal functions of the protein? Is this going to be detrimental to the health of the cells within the brain? And what we found was that the peptide only blocks the abnormal effects, but allows the normal cyclin-dependent kinase function to continue. So this picture actually shows cells with, here if you look at the arrow, talin and integrin linked to CDK5 moving. So these are endothelial cells, and they're basically able to undergo spreading, movement, migration, and angiogenesis in a normal fashion, particularly in the presence of this CYP peptide. Now, if you look at them in hypoxia, in vitro, in hypoxia, it doesn't happen, okay? So hypoxia kills the cells. If you add the P5 peptide, it works properly. So it protects them and allows them to undergo their normal function, which supports angiogenesis, okay? I think this is too small for you to see. All this is showing, we have to find a way to prove that the P5 peptide is in the cell and then it's released by the cell. So even though these are very small pictures, and there's lots of them, what it's showing is that we biotinylated the protein so we could fluorescently look at it, label it. Yeah? We're looking at it, and then we're saying, yes, this cell has taken in the protein, and over this period of time, the protein is released over 3 days. So that's all that is showing, and I wanted to demonstrate probably the amount of time and effort it takes to be able to characterize the protein before you can use it. And again, here we use liquid chromatography mass spectrometry to be able to identify the protein and quantify the protein. How much of that peptide is released? So many picograms per so many stem cells, which equates to, if you have 10 million stem cells, that would equate to about 5 micrograms of protein. And that would be sufficient in a volume of stroke, of stroke tissue, to block the pathway. So it would work. There's enough protein or peptide that would get in there. And then cell signaling studies, which just demonstrate that you're able to block phosphorylation or activation of the protein using this peptide. So what did we do after that? We took the stem cells, we added the P5 peptide, and we injected them into the brain of a rat. And this was our first small pilot study, and what we showed was that the motor function, cognition, and behavior of the rats was significantly better in the presence of, so here we go, the upper line. This is an example of adhesive tape removal, time taken to remove a piece of adhesive tape. There's many tests that we did. This is just an example. Was increased in the presence of the peptide and the stem cells. Okay, so stem cells make a difference, and actually the addition of the drug also made a difference. It's very, very early days. The experiment was conducted not really to my satisfaction, but it still showed an improvement. And we also showed that the stem cells were found in fairly high concentrations in the brain and remained in the brain over a period of several weeks after the injection, okay? And we also showed that CYP peptide was there, which is the P5 peptide. So, toxicity studies showed that the P5 was not toxic to the cells, and we have to be able to perform those. There's no decrease in cell number in the presence of the quantity of P5 that we're going to add to the cells. This is in endothelial cells, and now in neurons, the same thing, okay? So no issues with cytotoxicity or toxicity. The second molecule that we looked at, remember I said that University of Manchester spent 20 years looking at interleukin-1, and they failed. So we had our chemists look at the structure of interleukin-1 receptor, scan all of the literature, and what we've done is we found, or we asked them to design us a new molecule, which is an interleukin-1 receptor alpha antagonist, but it's a small molecule. They've constructed this molecule, we've tested it, and this picture here shows that when you stimulate inflammation through LPS here, massive amount of stimulation, interleukin-1 beta production, what happens when we put our mimic, so we're calling it a mimic for the moment, almost completely blocks inflammation, okay? So we're pretty excited about this. We've tested it with a number of other cytokines and other inflammatory molecules, and it's blocking them as well. So we now have then moved to the point of checking that it will go inside the stem cell and it will be released by the stem cell, and we've just shown that now. So what we're ready to do, I'm not going to show that yet. What we're ready to do is perform a new study, animal model study, where we're putting, we're co-injecting 2 drugs. One is anti-apoptotic and actually pro-remodeling, and the other one is anti-inflammatory, very strongly anti-inflammatory, and we're going to co-inject stem cells intracranially and see if we can impact on the stroke development and see if we can improve stroke recovery in the rodent model. And this is going to happen with our Fraunhofer partners in Germany, because they have an animal MRI and we can monitor hour by hour the effects on the stroke. So very, very briefly then, what is the other issue then? We say targeting. So how are we going to target and keep the stem cells where we want them? So the other thing that we looked at is the fact that if you incubate stem cells with paramagnetic iron oxide nanoparticles, such as those used in contrast imaging, that's very, very tiny particles, they take them in and it doesn't affect their function. So it doesn't damage them. There's no negative effects on them. This makes the stem cells magnetic. So what we've managed to do is, in vitro, show that we can move the cells around where we want them to after magnetizing them with these SPIONs. And we've done a small study, again in Germany, where we've injected them into the brain of mice, and we've used MRI magnets to move them where we want them. Does this start to make sense now? So what we're hoping to be able to do is to use the MRI system to magnetize the stem cells and then to hold them in the position of the brain that we need them to after stroke, so we get the maximum effect. And this should this should be much more effective compared to current techniques. And as far as I know, nobody else is doing this at the moment or trying to do it. So I'm going to skip through these because we talked about these. I'm not going to talk about lentiviral DNA insertion because I don't think we need that in terms of stroke. I mentioned at the beginning about delivery mechanisms, and we have this possibility. We can put them in the arteries or the veins. We can potentially directly inject through a borehole into the affected brain region. And I think that's going to be the most effective therapy. And there's one other thing that I would like to mention, which is very, very, very novel, okay? So, having spent 5 years looking at stem cells and realizing their potential in stroke, a company called Lipogems contacted us recently through our collaborators who are working with them and said, hang on a minute, we just found that we've got this system, which is shown on the right here, doesn't show much, but that's what it is, where we extract the tissue from the omentum, and it's a 2-stage system, and we're forming these things which we call lipogems, okay? And it's a 3-dimensional scaffold containing the highest quantity of stem cells of any part of the body, naturally, but also it's a scaffold which will allow drugs to be absorbed into it. So I said, hang on a minute, this sounds interesting. So it's a gel which you produce from the person very quickly and very easily with this system. But it also absorbs drugs. So how many drugs and what does it do with them? And they told me up to milligrams quantities of drugs, which can be released over up to a month. And I'm thinking, this is crazy. So in a couple of weeks, these guys are coming over to Manchester, the CEO of the company, together with the other collaborators, to discuss the potential to use these in stroke and cancer therapy, okay, to use this lipogem system. So a little bit of information there about how it works, but basically you can actually extract this material from a person, for example, any person, a person at risk of stroke, and store it. And from storage, very quickly, you can then use it. So you can use it already made, even with drugs loaded. So this could be a very quick and effective method. Should you be able to get this lipogem material into the brain and into the area that you want it. Now, so I thought initially of things like glioblastoma. When you remove glioblastoma by operation, you could insert this gel into the brain and it would be perfect, full of chemotherapeutic drugs. It's going to give you the best chance of, after having resected the tumour, if it's possible, of a longer term survival. How can we get it through a borehole by stereotactic injection into the brain after stroke? Not quite sure yet, but I think it would be possible somehow. And if it is, I actually believe this is a fantastic opportunity to look at a new therapy for stroke. So, to complete, there are organoids and small brains growing in the lab, so we're looking at better models, looking at how you can look at the neurovascular coupling. So these are additional sort of ways in which we can test these new methods out. We're also looking at this system of MEA chips, microelectronic chips, for looking at how neurons connect with each other and how they signal to each other. And I may have mentioned last time that we developed these methods now to the point where we're constructing special circuits, we're inputting something to them, and we're outputting the binary solution onto a computer. So we're looking at how neurons store memories, and this will help us in understanding how drugs can be effective in protecting the neurons. So it's like it's still an in vitro system, but it's better than anything that exists at the moment on the market. And that's all I've got to say. Thank you very much for listening.
Thank you, Prof, for this very informative, updated talk. And maybe you talk about things that is just happening. I was happy with your talk. And maybe if somebody has any question, please. Then I keep my questions later.
You know, I think it's a very interesting way, honestly, for the treatment of the stroke patient, especially the magnetizing the cells and trying to control the cells, take it to the target size where you want, where is the problem is. Do you think that in the future can we implement this type of treatment to other diseases?
I think this is the whole idea. I think already there are very strong thoughts, if not more, in terms of using this type of therapy in diabetic wound healing, for example. So that's a clear and obvious advantage, that if you can provide a wound dressing which you don't have to remove every day and change, which inhibits the healing process properly, which contains, so stem cells which are improving the wound recovery at the same time, and maybe a drug which is inhibiting glycation, inflammation, for example. This is perfect idea for wound healing. So wound healing, cancer, and any other targeting, obviously stroke, any types of stroke, and probably other things as well. Yeah.
So interesting.
Yeah.
Thank you, Professor Mark. I would like to ask you questions about the nanoparticle size you are using, because I just have some...
5 nanometers.
Where you make it, in Spain?
They're actually the ones that are used for imaging the brain normally. So they're actually given to patients for enhanced imaging during scanning. So what happens is they're so small, they get taken up and then they get released back into the circulation and they don't damage the body. So that's the reason we're using those, is because we know that they're not going to cause any damage. Very, very small. They're called superparamagnetic iron oxide nanoparticles.
The last question about the loading. I would like to know some
about the
loading of stem cells into mesenchymal stem cells.
Yeah.
What's the way? Because I've just been reading about it.
Yeah, so there's several different ways, but clearly the most effective, especially during our testing time, would be stereotactic surgery. Okay, so it's very precise surgery. You place a scaffold over the animal's head, for example, or a person, if it is, yeah. And then you have a Hamilton needle, very, very fine. You drill a very fine borehole into the skull. Okay, you're imaging at the same time.
I think he's asking about loading in the stem cells. The drug in the stem
Oh,
cells.
loading the stem cells. Oh, okay, sorry. I'm glad because that's an easier one to answer. So, loading the stem cell, the drugs into the stem cells is easy, okay? So anybody can do this. So basically, if you just take if you go into tissue culture and you culture your stem cells and apply your drug to the tissue culture dish, it will be taken up by the stem cells. But what you need to do is fully characterize, so not all drugs will be taken up. This is why we have to make new drugs sometimes in order to change, because some of them are not,
دكتور تفضل. First of all, I would like really to thank you for taking us through this beautiful journey. It was so interesting to really go to the, I would say, to the neural level. At the same time, I would like to ask you, Dr. Mark, about the clinical trial. I think we're coming from different kinds of school. I'm coming from the you're coming from the preventive school, while I'm coming from the treatment and diagnosis school.
Yeah.
So do you reckon, taking the clinical trial, that will raise a question, how far do you think, from your own perspective, are we going to achieve to the optimal preventive from that ischemic kind of disease? And the another part of it, do you reckon the stem cells, at least, as in one type, from your own beautiful clinical trial that you've done so far as it's 2 stages, do you reckon and do you find it, is it really significant to really to proceed and to continue this clinical trial?
Okay, so looking at the last part of the question, I think clearly it makes sense that as we get older, I think the number of stem cells which are residing in our organs and tissues reduces. This is one of the disadvantages of our aging, and the fact that many studies now in animal models are using aged animals to try and mimic that sort of effect. Now, earlier on, there's a quite a large quantity of hiding stem cells or pluripotent cells that are able to differentiate, and you see this plasticity within the brain. So, I think it's almost a normal mechanism that the body has to try and replenish damaged cells in different, particularly in the brain, is to use those neural stem cells that reside within the brain. So I think that it makes sense to use to try and enhance that as a mechanism. The stem cells themselves can be utilized for at least 2 purposes, and one is directly as a cell that differentiates, and secondly is as a production of growth factors and cytokines, which are very positive. So I think that it's the most promising, realistic therapy, future therapy. But I think that none of these trials that are ongoing or have been, but have contemplated the use of drug-loaded stem cells or targeting.
And the second part, and I'm really sorry taking all of your time, but I can see there is a big play for the microimaging technique, as you've been using the region of interest and also a counting of the cells. So I would be so interested to really to collaborate with you and working on different kind of imaging techniques, such as segmentations and other techniques. So it may gonna really get you to the result that could be more accurate and more really interested to proceed in the future.
Yeah, no, I think so. I think remember I showed the study which was a bit of immunohistochemistry, and this is. So this was done by a group of our collaborators, and it was only to demonstrate, statistically, was there any effect on the animal in terms of improvement. There's no MRI, there's no CT, so that's why we're moving the real study to Fraunhofer Institute, where they're conducting this type of study in and out every couple of months. So everything will be characterized. We need to define the endpoints, the comparison points, the groups. So the groups, for example, stem cells versus stem cells plus drug is a critical group, isn't it? And so it's going to be it makes it a big study. And actually, The one thing I haven't mentioned that I was going to mention, which is a little bit off the label, but is this paper that we published, for example, in Stem Cells International.
Yes.
You know, which we had a bit of support from Majma as well. But the cost of running those experiments, which didn't include in vivo, so the cost of publishing that paper was about £100,000 in terms of the cost of the people's time and consumables. Now, the cost of publishing the next paper, which will be an in vivo study, will be £500,000. And that hopefully will go in a journal such as PNAS or something like that, if the results are interesting.
Yes.
But where does that money come from? You know, who's paying for that? I say that to our university regularly, and they don't get it. They don't understand the true cost.
Yeah.
They say, "Oh, you produce four 4-star papers every year," and I say, "Okay, give me £2 million." You know,
Yeah.
and also it takes 5 years.
It's really like, you know, a big
Yeah.
project. So I'm so thankful really for your time and for your
Pleasure.
Thank you for your presentation, Prof. Mark. I think just from a genetic point of view, is there any gene involved direct to the stroke? Like, for example, if we say LDL receptors, it's due to the atherosclerosis, but is there some like genes that's involved? As you know, the genetic is very important in the.
Yeah, I mean, I think that there's mutated genes which predispose people obviously to developing atherosclerosis, for example, or hemorrhagic stroke, for example, or damaged vessels in the brain. But okay, gene therapy, I think, I mean, it's been tested in Parkinson's disease, and I think, I think there's it's going off the boil a little bit. I think gene therapy with long-term therapeutic effects with lentiviruses is always going to be dangerous, and I think we wouldn't. I can't see it being used as preventative medicine. The other thing is in terms of what we've been thinking about in terms of blocking the development of atherosclerosis, because clearly our vascular system has not been made properly. Okay, so we have problems with shear stress. Okay, and where there's high or low, very low shear stress, you get points in arteries, such as bifurcation points, where there's a hot spot for development of damage. And as soon as that damage occurs, then you start developing a plaque over 10, 20, 30, 40 years. And at some point, something changes in the environment and you get erosion, for example, and then a thrombosis, and that thrombosis gives you a heart attack or a stroke. Now, those plaques usually are like, the unstable plaques, the dangerous ones, are like cancer, little tumours. They require blood supply, and that blood supply is a hemorrhagic blood supply, and it also contributes significantly to the inflammatory aspect and the instability. So one thing we thought of was, apart from something which will, again, I think it sounds like science fiction. I like to talk about science fiction, but these nanorobots in the future, nanosensors, are going to be inside our bloodstream, repairing the endothelial cell layers of the major arteries, and this will slow down atherosclerosis, and this is probably going to happen in 10, 20, 30 years. But in the meantime, if you were able to block the vasovassorum activation, so the vasovassorum in the adventitia, it has been shown that those endothelial cells migrate into the growing plaque and allow its development and growth. So if you were to say, well, okay, we know the plaque's going to develop here. These are the vasa which are linked to it. We can actually inject those or target those with some anti-angiogenic molecule to stop them from proliferating. So their microenvironment is just their microenvironment, not the whole vascular system is affected. Then you may not develop much of a plaque. And if you do, it might be more stable. So you might actually just end up with angina when you're 80 or 90 and not have a heart attack or a stroke. This new therapy, which is stem cell stroke lipogems, what I would like to think is that the in vivo study will take place in Germany. Lots of the in vitro will take place in the UK, but I think that there's also some expertise here in nanotechnology, and I think that to actually characterize the way that we're going to be able to target the stem cells, for example, using these SPIONs, and maybe, you know, it's going to require a concerted effort. It might be where we can all collaborate together. When we put those bits together, we'll be ready to actually undergo the trials. Yeah, I think that we can look into the possibility of patenting these things. Yeah, for sure.
Okay. Before we conclude, can you tell us when this drug, loaded stem cell with the drug, is going to be in a clinical trial? Just a rough estimation.
Yeah. So this is a very good question. I think that the proof of concept work will be okay. We have the advantage now. The stem cell trials are going ahead, so all we need to do is show that there's no cytotoxicity linked to the drugs. And then we can, once we've got a proof of concept that there's a significant advantage, so this will take a couple of years, 2-3 years, then we can ask to try to get to a phase 1 clinical trial with them. Okay.
شكرا لكم. نشكر لكم حضوركم واستماعكم لبرامج الملتقى الرابع لأعمال كرسي الشيخ عبدالله بن عبدالمحسن التويجري، ونشكر المتحدثين في هذا الملتقى ورؤساء الجلسات العلمية وتكريمهم. فليتفضل الدكتور ثامر الحربي عميد البحث العلمي والدكتور رائد البرادعي المشرف على الكرسي. الدكتور خالد التهامي، الدكتور مازن القحطاني، الدكتور عبدالله عثمان العامودي، الدكتور الصادق يوسف، الدكتور عبد الرحمن بن محمد السليمان، الدكتور خالد بن محمد العبد الوهاب، الدكتور خالد الغامدي، الدكتور مارك سليفن، شكرا لكم وشكرا لدعمكم.